Welcome everybody to the Wednesday webinars organized by Fascial Manipulation Institute by STECO. Today for us, it's a great pleasure to introduce you Colleen Whiteford and her speech, Urinary Incontinence. Dr. Whiteford graduated from St. Louis University, St. Louis, Missouri in USA in 1984 with a Bachelor of Science in Physical Therapy and received a Doctor of Physical Therapy degree from Shenandoah University, Winchester, Virginia in 2011. Board certification as orthopedic specialist was awarded in 2000 and renewed in 2010. Dr. Whiteford has worked as a full-time practicing clinician and owner at Appalachian Physical Therapy since 1986, long appreciating the role of soft tissue in pain and movement dysfunction. She became certified in dry needling in 2010 and joined the Faculty of Myopain Eureka seminars in 2012 to assist with continuing education courses on dry needling and the fascial manipulation by STECO. She has completed over 400 hours of formal training in FM, and in 2018 traveled to Italy for further training and testing to become the first physical therapist in the United States certified in this approach. She contributed a chapter on resolving urinary incontinence in a postpartum runner in a 2018 book, Fascial Manipulation, the Practitioner Perspective. She returned in Italy in 2018 and was awarded certification as instructor in the Fascial Manipulation STECO by STECO method. So the platform is for you, Colleen, and I want to remember to our colleague that it is possible at the end of the speech, but also during the speech, to try question about the question. It's possible with the platform. So the platform is yours. Let's go.
All right, thank you, Carmelo. I need to shorten my bio, a little long. So hi, everyone. Thanks for joining in today for this Wednesday webinar on urinary incontinence, which is, I think, a very important thing to take a look at. So let's take a look at it. And I want to start with a story about Mary. That's not a real name, but she was a real patient of mine. She was a 50-year-old woman who had a lot of problems when I met her, and she had a long history of digestive issues that dated back since childhood, and she had more recently as an adult been diagnosed with irritable bowel syndrome, and she was waiting for a consult with a gastroenterologist to give her more direction with that. She had menstrual disorders since she was a young girl, heavy bleeding and cramping. As is often the case, she would miss school, then later in life she would miss work because of it. She was never treated for it in any manner. Later in life, she had 4 children, 3 vaginally and then 1 by C-section, and she began to develop worsening problems with urinary incontinence over the years. With frequency, urgency, incontinence, she had post-void residual, meaning she couldn't fully empty her bladder, and she just had difficulty performing urination at all. Then in, I think it was around 2021 or so, she found a small lump on her abdomen, and she palpated it herself, and so she went and consulted her primary care provider, who performed an ultrasound, and they didn't find anything with it, and so they determined that she had a diastasis rectus abdominis. They gave her some exercises, and it didn't do much for her, but she just kind of let it go and continued to monitor herself. Then in 2022, she had episodes with fecal incontinence. One time when she was at work and she lost complete control of her bowels. She went to the emergency department and she was checked out over there and they couldn't find anything wrong with her. So she left, and then 3 weeks later, she had a similar episode while she was out for a walk. And she went back to the emergency department and she was told the same thing, that there was nothing wrong. And so she was a little frustrated with that, but didn't know where to go with it. And then she came to me. So when she presented, she drew, we always have people draw a diagram like this, And this is what she gave me. She didn't know how to fill in symptoms for fecal incontinence, urinary incontinence, and for a diastasis. So she didn't draw anything. Then she also rated her symptoms middle of the road because she really didn't know how to give them a number because it wasn't exactly pain. After I got her history, I filled in a lot of what you see here, including she had some traumas. She had a four-wheeler accident, for one. She hurt her neck and that. She'd broken hands and feet, hurt her ankle. She had knee issues. She had bilateral hip symptoms ever since she'd had children years before. At the bottom, I make a timeline. Like you see there, the digestive issues were considered to be her oldest problem, and also this diastasis, as well as that lump she felt on her trunk. I didn't have the urinary on there, but it was somewhere in the middle. She wasn't exactly sure when things began. So just like with a musculoskeletal problem, I like to select parameters that would mark change with a urinary problem. And even though she was more than just urinary, I'll just focus on the urinary. And for her, it looked like this. So nocturia, how many times she would get up at night to go to the bathroom, was 1 to 2 times. 0 to 1 is normal. And she really struggled not to go to the bathroom more at night. Another parameter that we noted on her was that she would wear urinary incontinence pads, a number 1 pad when she was active, and she would go through 3 to 4 of these per day. To put it in perspective, one of these pads can hold a fully emptying bladder, which is roughly 2 cups or about 500 milliliters of fluid. And she would go through several of them throughout the day. So her problem was pretty troubling for her. Another parameter was just that she reported the issues with frequency, urgency, and difficulty emptying, and these were worsening for her. And lastly, a parameter we were marking was the episodes with fecal incontinence, but she hadn't had any more than the 2 that she had reported to me initially. So when she arrived, I looked at her structurally. There wasn't really anything significant. Surprisingly, her feet were good. I'm looking for bunions and hammer toes and significant pronation, supination. She didn't have scoliosis. She didn't have leg length discrepancies. So nothing really major structurally. In movement testing, I like to use a squat. And with heels down, this was about where she was. She was pretty restricted. She didn't want to go lower because she was afraid that if she went lower, she wouldn't be able to get back up. And when I let her take her heels up off the floor and then do the squat, she could go much lower. And what that tells me is she's probably got some kind of restriction in the calf or in the foot that's interfering with her ability to go lower into her squat. So it's something I want to know and investigate further. I palpated her abdomen just in an effort to assess this diastasis that she was told that she had. So I'm palpating the linea alba, midline, right between the 2 halves of the rectus abdominis. And I did not feel any kind of separation in the 2. I had her lift her head also, which that can make the 2 halves become more prominent if they're separated. It'll sort of accentuate a diastasis. And I never felt like she had a diastasis, so I just documented that there was none there. Now, moving on with palpation then, what I'm interested in here is looking at, okay, what's going on with the deep fascia? And in a pelvic patient, I'm especially interested in what's in the deep fascia in terms of densification in the segment of the pelvis and in the segment of talus. I start in talus, the ankle region and the calf, because I feel like it's a little less threatening to people and they get used to my touch and I get used to how are they going to respond to my touch. So I begin in talus, and what I found on her was much involvement in the anterolateral diagonal, in the retrolateral diagonal, and also in the horizontal plane. And when I followed this up into the pelvis, I found the same, anterolateral, retrolateral, and the horizontal plane. And when I took it a little further up into her neck, because she had neck symptoms, I also found similar findings in the plane and in the diagonals. So we went to work on her. Fascial manipulation is my go-to, and I used that on her from the beginning. I teach from my website, fearfullywonderfullymade.life. I have a lot of information on there that I made for clinicians, but also for patients, so I don't have to spend my whole treatment encounter with that person teaching them about why I'm interested in their ankle when they came to me for their bladder. I use percussion and vibration tools, and I like to teach people how to work on themselves at home with those. I use a few key exercises, and I teach a lot about activities of daily and nightly living that somebody might be doing that are feeding into their problem and perpetuating the issues they come for. And so I did all that with her. And I saw her for 3 visits, and then we had over 5 weeks. We had a little bit of an interruption due to the holiday season. And after the 3 visits, she reported that she no longer needed to wear the urinary incontinence pads, and she was not getting up anymore at night. So after those 3 visits, we continued to work with her on the multitude of other issues that she had. But it was just a nice example to me, and I hope to you, of how quickly you can make a change that's really meaningful for somebody with their bladder issues. And Mary is not alone in this problem by a long shot. Unfortunately, there are an awful lot of people who share the same issues that she has. And here are just some of the statistics that I found on urinary incontinence. And it's talking about in the United States, but also worldwide. It's not all older people, and it's not all women, but over the age of 18, they were even looking at that young. They're speaking here in one statistic about how long women wait before they'll seek help. And it might have been like Mary, that she just figured, well, I'm 50 years old and I've had 4 children, and this is just the way it is. And that also there's just such high numbers of 15 million adult women in the U.S. dealing with some form of urinary incontinence. You know, this really can be a life-controlling issue for people where they're constantly having to scope out the landscape and figure out, where is my next restroom? And sometimes they won't go somewhere if they're afraid they're not going to be able to get to the restroom in time, because there's not always a restroom close, like in a park or even in a movie theater, or if they don't know, but they're not familiar with the territory, they don't want to go through the embarrassment of having an accident. And there are a lot of economic burdens that are associated with incontinence as well. And this is just looking at, in the United States, some of the estimates for what it costs. So the OAB is overactive bladder, and UUI is urge urinary incontinence. In 2007, just in the U.S. alone, these were estimated at almost $66 billion in costs. And looking at projecting over time from this study, that it's only going to go up, which is believable. And the personal expenditures that this puts on people makes them willing to pay to have a treatment that will do more than just manage the symptoms. So these pads are very common, they're easily available, but they cost roughly, depending on what quantity you buy them in and what size of absorbency you buy them in, but they're roughly 75 cents to $1 for what I looked at in the US, and they might be a different price even in other countries. That may not sound like much, but if you're going through multiple pads day and night, day after day, it does add up. And the cost isn't just about the pads. This study looked at the costs that went beyond the pads and included things like cleaning, laundry, other factors as well as the pads. They came up with $900, and I think this was a 2006 study, so it's only gone up. And actually, I would have thought it was higher, so sometimes people aren't reporting everything or nobody's asking the right questions to get the right number. One thing, too, that I think urinary incontinence does to people that we have to appreciate is it can be very isolating. Somebody may decide they're not going to go out because it's safer to stay home, to be inside and miss out on social or other events because they know where the bathroom is at home and they can get to it in time. If they have an accident, they're in their environment. It's very sad. And so we deal with it by making jokes about it. And it's so common to hear people say, I laughed so hard I peed my pants. And it's kind of commonplace in our verbiage, but it's really a sad reflection on it. And it's not just adults. I found this on the internet, riddles for kids. And this kind of mindset is permeating even kids' minds and language. So these advertisements would almost be trying to make you feel like there's some kind of weird fellowship or club that you're in with urinary incontinence, and they sort of make it look like it's fun, or even in some respects downright sexy to have urinary incontinence. And hopefully, I guess that sells pads. But this isn't just a woman's problem or an old lady's problem. I mean, adolescents and children are afflicted with this problem too of urinary incontinence. Also men, especially post-prostatectomy, the rates are really high that after a prostatectomy, the urinary incontinence will be a problem for men. So this takes on a personal note here. This is my sweet mom, And I think she looks great. This is her on her 90th birthday. So, and that was 4 years ago. My mom had 11 pregnancies, 9 children. I'm number 7. Mom also struggled with urinary incontinence all her life, and she continues to. She had 5 bladder surgeries. She went through lots of pelvic floor therapy and did a lot of different injections and all sorts of procedures and protocols for people. In spite of all that, she remains very incontinent. And it's kind of heartbreaking, but she's an example of the failure of our system and our current model to adequately address this problem and make a substantive change for people. And I think there's a lot of reasons behind that. I think a lot of the failure with the system is that, oops, I went too far. It takes, I'm going to get messed up. Yeah, I like this slide. I use this a lot for different reasons, but I think our current model sort of is reflected in this. I think it's because our model is based on a lot of misconceptions, untruths, and just misrepresented information that leads people to the middle of nowhere. So what I want to do is take a look at what I've built here are what I believe are 7 myths that perpetuate our lack of success with treating urinary incontinence. The first one is myth number 1, that strengthening is what we need, and that Kegels are the answer to all pelvic floor problems. So Kegels date back to Dr. Arnold Kegel, and he published his first article in 1948, and he talked about his success in curing urinary incontinence by having women do pelvic floor muscle training exercises. And what's good to note is that Dr. Kegel really didn't invent the pelvic floor exercise, because it's been used for a very long time before he ever became known and was ever even born. But he gets credit for having created the construct, and he certainly did promote it more. He claimed to have 84% success rate with his exercises, but his studies weren't very robust. He didn't have a lot of great outcome measures, and nobody's been able to reproduce that kind of result since then. So, but yet, in spite of the lack of evidence that would support Kegels as the go-to, it remains the number 1 prescribed exercises for pelvic floor, even 75 or so years later, without real evidence for it. This is not an old access to the Mayo Clinic website, and this is a website a lot of people consider to be like cutting edge and frontline, top line information. And it's just reflecting a very old exercise that doesn't have a lot of evidence behind it. So this is from the Journal of Urology, and writing about managing interstitial cystitis, which is basically bladder issues, and urge frequency syndrome, again with the bladder, and looking at myofascial trigger point therapy and exercise. And they said with the subjects in there, they stopped making progress, and they blamed it on the fact that they didn't continue their home exercises of stress reduction as well as Kegels and their physical therapy program. So all over the literature, though, across different influences in healthcare or anything, patient compliance with exercise programs has been shown to be pretty poor. It starts out good, and then it just drops, and especially once people are out of their program, they tend to not follow through with exercise anymore. So this is a real problem if our model is dependent on people doing these exercises in order to accomplish a change, especially with their urinary incontinence. So this was an interesting study. It was 2-part study. The first one was done in 1990. It was done by Kari Bo, who is a Norwegian physical therapist and researcher. And they looked at 52 women who had urinary incontinence. They divided them into 2 different groups. They all got a home exercise program that was very similar for pelvic floor muscle training. But what they did with one group was they also did an intensive exercise program with them, where they went for 1 time a week for 45 minutes with an instructor. They didn't say it was specifically a therapist, but whatever, who worked with them on making sure they were doing a slow twitch, fast twitch contraction. And these women were doing 3 times a day, doing their exercise program pretty religiously, or at least they indicated they did. So at the end of it all, the intensive exercise group with the coaching had more improvement than the non-coached group, but they both had a little bit of improvement in it. But ultimately, the results were that they concluded that it depended on how long they stuck with the therapist and how well supervised they were with their program. So it was very dependent on them being in a formal program. Then 15 years later, they came back and they surveyed these same participants from the prior study that I was just talking about. The results were not very good. So they looked at them and found that 28% of them were continuing their pelvic floor exercises 15 years later. That's impressive, really. Those numbers are a little better than normal. But the two groups reported no difference in how they were with their bladder issues and their satisfaction with their problem. One half of both groups had undergone surgery, and sadly, the surgical group had more issues with incontinence that interfere with daily life than the non-surgical group. So not a great outcome at all for demonstrating the efficacy of the pelvic floor training. So, and that's what they concluded with this, that it wasn't seen. It was seen short-term, but it wasn't maintained years later, that the high-intensity supervised group didn't do any better than the non-supervised group. And they just suggest that we really need to take a look at how we're managing urinary incontinence. Another article showing similar findings and basically saying that, trying to advance it here, let me advance, there we go, that in the results from this, they looked at 70 women, only 16 of them seemed to have benefit from doing the pelvic floor muscle training. They cited time constraints as well as cost constraints because we're back to appointments and needing a clinician to help guide through it. They concluded that the effectiveness was pretty low, basically, for pelvic floor muscle training. So this study was a 2008 study, and they looked at quality of life outcomes, and they were looking at just using pelvic floor muscle training and how practical was it for this group. And they were finding that the exercises were really burdensome to most of the women in the group, and that there was so much variance in how these exercises, Kegels, were prescribed for them. Some were told 3 times a day, 3 times a week, 15 to 30 to 100 times a day. That's a lot of variance. And ultimately, they said, given that there's poor long-term pelvic floor muscle training adherence, it really ought to be a priority to figure out, what do we tell these people they're supposed to be doing? Because it really is all over the place for instructions. I kind of liken it to, like, let's say somebody comes in for knee pain. It doesn't matter what's causing their knee pain, but we give them quad sets, and we just tell them, we don't know how many you should do. Just do them all day long, whenever you think about it. Do them for the rest of your life, and we'll hope for a good outcome with your knee pain. And that's sort of how we treat Kegels in some respects. So myth number 2 that I want to look at, since myth number 1 about the strengthening being the answer really wasn't stacking up, we started to see a shift in the literature that went more towards thinking about maybe what needs to happen is the pelvic floor is overactive and it needs to be relaxed instead. And the literature begins to reflect this, that biofeedback, which was typically always used for contraction and giving feedback on strengthening the pelvic floor, now is being used for going the other way and relaxing the pelvic floor. And over in the literature, you'd see terms like a non-relaxing pelvic floor dysfunction that spoke to this hypertonicity instead of the weakness being the problem. Overactive pelvic floor muscles, new terminology coming up and showing just more diagnostic studies to try to really be accurate with that. This article this was 2007, looking at the timing. So they found that with shoulder movements, that the timing of a pelvic floor muscle contraction in conjunction with arm movement was delayed in women who had stress urinary incontinence than in the women who didn't. And, I would suggest that if the strengthening and the relaxing theories or hypotheses were really being effective, we wouldn't be seeing these kinds of numbers that are still occurring with so many people struggling with urinary incontinence. And maybe it's because we're sort of overlooking the bare bones physiology of how the muscle spindle is embedded in a fascial matrix, as Carla Stecco has shown with a lot of her work, and that the spindle and the tendon organ are counting on an elastic, stretchable matrix that will allow them to perform properly. It has to be in an adaptable matrix or it won't contract properly. That might mean turning on, it might mean turning off, but we don't talk about that when we just focus on our stretching and strengthening of the pelvic floor. So myth number 3, only certified pelvic specialists can treat bladder problems. This is one of my favorite ones. In the United States, I don't know what it's like all over the world, but I tried to pull up some of the requirements to become certified as a pelvic health specialist or a women's health specialist. It's a daunting list. It's a huge curriculum that involves a lot of coursework, clinical hours, writing papers, research reports. It's quite daunting. And I am an orthopedic certified specialist, so I have a sense of what this is like, but I never did the pelvic certification. There's a lot of requirements that take a lot of time, money, effort, and focus. And ultimately, hopefully, it culminates in qualifying to take the examination, and then you become certified as a women's health specialist. This is very daunting to a lot of people. A lot of people don't have the time, money, or the focus to put into that. But what I would suggest is one element that is really unique to the pelvic specialist is that this is the only specialty that focuses on internal pelvic examination. And this is kind of the hallmark and the emphasis in the education for the pelvic therapist, although it's not the only component. It's a huge factor. And I would suggest that this element alone is one of the biggest turnoffs, I don't have another word for it, to a lot of people being willing to consider doing pelvic care because they think they have to do internal pelvic examination. It's incredibly intimidating, and it'll make a lot of people who look at pelvic care who aren't trained that way just say, you know what, I'm not doing it. I'm not going there. I don't want to do internal pelvic. I don't want to do all that training. But I'd really like to suggest that there is another way to think about this. For me, I didn't go through all that pelvic training. I haven't been classically and traditionally trained in pelvic care. My training comes much more from fascial manipulation. But in learning this whole construct, it's shown me how to look at the body globally. And in that, then, that happens to encompass the pelvis. And as I began to get results with pelvic patients who were coming to me for any number of reasons, it just continued to grow from there. And now pelvic pain and pelvic patients for a variety of diagnoses are the main part of my practice. Sometimes people come specifically for pelvic problems. Sometimes it's for orthopedic problems and pelvic problems. I don't really separate them. I don't think you really can. And I think that's where we get into trouble is we try to carve out the pelvis from the body. And in the fascial manipulation model, I love how it's seamless. And it's really neat to be able to incorporate that into all my care. Carla Stecco's beautiful work with dissections, especially of the abdomen, shows this, and the relationship and the seamless nature of the pelvic region into the other parts of the body, including the pelvic floor. And that's what she's saying here, that scarpus fascia moves toward the pelvic floor. It's in total continuity. And appreciating this anatomy, then we can say, well, any type of alteration can transmit the wrong tension that may manifest in the pelvic floor or in the organ surrounding. Same thing with the deep fascia of the pelvic region continuing into the fascia lata of the lower limb. So this fascia plays a key role in stretch mostly toward the medial region of the adductors. And any kind of abnormal tension can show up as a problem in the pelvic floor. And maybe that's why we see these sorts of illustrations in this famous model, the trigger point manual, where there's such strong referral from the adductors up into the pelvic region. And why the adductor region, but the fascia of that area too needs to be considered. This study in the Journal of Anatomy was just looking at this very kind of relationship, where they were even going so far down as the medial gastrocnemius and showing a relationship between movement in the medial gastrocnemius having an impact superior up into the pelvic segment. This newer article that just came out this year from the research group in Italy was looking at not only is there a relationship in remote parts, and for this it was the lower limb impacting neck range, but it even had directional specificity where stretching the hamstrings in the sagittal plane made changes and improvements in neck range of motion, again in the sagittal plane. So it's pretty interesting to think about myofascial sequences then. So as a non-pelvic therapist, as Carmelo mentioned in the introduction, my chapter in this book was on returning a postpartum runner to running who was struggling with urinary incontinence. And remember, I'm not a classically trained pelvic therapist, but she had issues with running. She couldn't run anymore because of urinary incontinence. She also had a diastasis rectus abdominis, and she sought care from traditional pelvic therapists for it. She was very meticulous with her exercises. She did internal pelvic work. She was still very incontinent. She couldn't get back to running. And so she showed up in my office because she learned we had something different to offer. I identified ankle sprains and other problems being a problem for her. We worked initially down in the foot and in the pelvic segment. And after one visit, she got back to running with not urinary incontinence being what stopped her, but knee pain. And so we continued to address that on her, as well as other issues that she had with headaches and doing some running analysis. And within 7 visits, 2 of them were not with fascial manipulation. So 5 visits, we resolved her urinary incontinence. And this was maintained when I saw her a year and a half or 2 years later, even for another ankle sprain that she had acquired. So it's pretty neat what you can do when you know how to work with this model. And looking ahead now, number 4, my myth number 4 that I made, you need specialized equipment and training to work with bladder problems. So I have a picture of lots of different gizmos here, and I can tell you, so down in the left-hand corner, pessaries, there's vaginal weights, internal and external electric stimulation, dilators, vaginal dilators, biofeedback, ultrasound. I can tell you, I don't use any of those in my practice. So this study from 1999 looked at comparing exercise, electric stim, vaginal cones, and no intervention. And what they found was that pelvic floor muscle training was superior to these other interventions and these gizmos. But remember, just because it's superior doesn't mean it's good. We already looked at that. This was looking at 10-year outcomes for women who use electric stim. 10 years, most of the women had symptoms of urge incontinence. Looking more at intravaginal electric stim, and again, the findings were not very encouraging in that they had partial improvement. I would liken that to partially fixing a leaky roof. How satisfying or effective is that? And can't we do better? So myth number 5, bladder problems are best managed with medications and supplements. So there's a lot out there on the market for both prescription and non-prescription. The United States and New Zealand have the most permissive direct-to-consumer pharmaceutical advertising in the world, and maybe other countries have joined the ranks. But we see ads like this all the time, and so patients are very much aware of their pharmacological options. But unfortunately, these have not been found to be terribly successful either, as these studies that I'm going to show you portray. So almost 92% of the patients on this one failed to meet their goals in 2 years with use of them. This study looking at just a newer drug coming out, but here was the problem with it, all these side effects, one of them being UTI. That seems kind of ironic, but most people discontinue their medication use because they don't want to live with all these side effects. They feel like it's better to live with the incontinence. So myth number 6 of 7, I have 7 total. Bladder problems can be cured with surgery. So this is just, I have a series of articles here showing that they're talking about the second line, meaning after the first one fails. There's a lot in the literature now, because the failure is so common, about how to manage the repeat surgery. And the literature is very full of how unsatisfactory the outcomes are with this, whether we're talking surgery or taping, and finally looking at vaginal vault prolapse. And they're coming to the same conclusion that vaginal vault prolapse, just pelvic organ prolapse, which often involves urinary incontinence as well. The best approach, they're determining, it just remains unknown. And finally, then, we see a lawsuit, a class action lawsuit surrounding using pelvic mesh that really caused a lot of problems for women. And then remembering my mom with all her surgeries and how, unfortunately, unsuccessful a lot of those have been for her. So, last myth, number 7. There are multiple diagnoses, and a precise diagnosis as well as a very specific treatment protocol is necessary in order to have a successful treatment outcome in managing. Well, it is true there are a lot of diagnoses for bladder problems, and looking at this can be overwhelming and intimidating. You might think that there's a separate protocol for each of these, and perhaps some people do have a separate protocol for each one, but I would suggest that many of these diagnoses don't have clear criteria for inclusion or exclusion. So some of it might depend on who is giving the diagnosis as to which way they want to name this or what they think it's presenting as. And a second problem with a lot of these diagnoses is that a lot of them have very similar and overlapping symptoms. So it's hard to draw the line between, well, which one is it? And on that note, I don't differentiate very hard at all. Because I'm just working with the fascia, it's not really important to me that I differentiate a specific diagnosis and come up with a very specific protocol. The way I approach it covers it all. In that, I think more of the problem is just the environment. It's not the organ that's the problem. It's not the bladder that's the problem as much. It's the environment, the fascial environment in which the bladder is trying to function. And when that's faulty, then we're going to get faulty output from the organ itself. And that's where I put my focus and not on a specific protocol. Multiple tests for bladder problems are certainly available. There's no shortage of tests for most diagnoses. But the problem with a lot of these is that they don't really do anything to help direct or guide treatment. An example is a lot of people have symptoms as if they have a urinary tract infection, and yet they're getting urinalysis, and there's no white blood cells, their urinalysis is negative, and they're told they don't have a urinary tract infection. It doesn't mean they don't have something wrong. It just means it's not a bladder infection. So where does that take us? And what can we do? If I don't do any of these things, then what's left? Well, we have a lot of neat options, and I think fascial manipulation is really one great source that is my go-to in treatment. And I use that with pretty much everybody, although that is not the only intervention that I use. I'm trying very hard to advance this slide. There we go. So for me, it begins with the history, and the history is all encompassing. I want to know about all the musculoskeletal problems. I draw them in on the diagram. I want to know site of pain. Maybe that's the back. Maybe it's the bladder. Maybe it's somewhere else. But I want to know all the problems that they have, internal organ and otherwise, because it's going to help me know where I might be focusing and working on someone. These are the parameters that I'll use to mark change in a urinary incontinence or other bladder problem patient. I want to know how many pads are they using in the day. Do they have to change clothes? How many times do they get up at night? How many times are they going during the day? Are they really, really struggling with urgency? Is there any episodes of unintentional loss of urine at all? Dealing with men, their problems are usually different. Are they taking a medication or using an herb that if we could get them off of it, then that would signal that there's improvement? And a note that I just want to mention here is don't overlook the bowels, because constipation can drive incontinence as well. And I have a note there about using a diary. These are on the internet, and a lot of therapists do use them. I find they haven't been that helpful for me, and for the most part, as long as I set up parameters for where we're starting with someone, then I can mark change. And usually people they don't want to keep these anyway. So I don't mess with them, but they're a legitimate form of documenting change with someone. Bladder irritants are good to educate people on, and I only say that in the sense that if somebody's working with trying to change their problem, but in the meantime, it's good to let them know that these things might not be a good idea to eat before you get in the car or before you get on a plane, eat or drink. because they're going to have a tendency to trigger your bladder and make it a little more sensitive. Ultimately, my goal is to get them to where they can eat these or drink these things and they're not so sensitive to them. To me, that would signal improvement. But it's good to be aware that these are the triggers. Inspection and observation are tools that I use. I want to know what are clues that the body's giving us that it's in distress, whether it's in the feet, the lower limb, in the posture, anywhere. I use movement when I'm working with a bladder patient. It might give me information about a problem segment. It might not. They might move fine, but I use it anyway so that it helps me be able to measure change in the person. I also use, but I only use movement. It's not advancing. I only use movement to serve mainly as a measure of change. That's what it's helpful for, as far as I'm concerned. And then I can measure a difference in somebody. Palpation, of course, is very helpful for palpating the superficial tissues, but also the deep, to know what's going on in the deep fascia and where do I need to be working on this person. I'm interested in the segment of talus, as you've already seen me talk about, and I'm also extremely interested in the segment of the pelvis because this is where the bladder is housed. So I'm going to consider these two segments very carefully, but I'm also going to look at others as well. I use education through the brochures that I've created in the clinic to educate people as to any other type of influence that might be playing into their problem. And we give these out, but I also use my website regularly to help people learn more about fascia, more about fascial manipulation and how it applies to their condition. I use a few exercises, but I don't count on the exercises to make the change. I just use exercise to support the changes. And I like doing fun exercise. I love hula hoops. It's a great mobility and stability game changer for people if they can do it successfully. All these diagnoses, yeah, they can be a little bit overwhelming. But I hope you can see some possibilities here, especially when you know an intervention to tap into like fascial manipulation. Maybe it would help remove some of the intimidation of approaching the pelvic problem, such as any kind of bladder issue. And not let that be what stops you from looking at the pelvis. So here is my contact information. If you want to reach out to me, the best way is by email. That's my email address there. And I hope that you'll take a look at the website I've created. It's really, I'm biased. It's pretty cool because it's just got a lot of information that I think is digestible for patients. And that's who I really targeted it toward, so that they understand what's going on with their body and just trying to equip them. And if I can advance this, that's my last slide, but I do want to say thank you to all of you for joining in. I appreciate my husband's support in my work as well as our dogs, but thank all of you too for just taking the time to come and be with us and learn more about bladder issues and helping people with them. So thank you.
Thank you, Colleen, for your speech, for this huge discussion about the urinary incontinence and also the relationship with I ask you if you can a little bit remove the tone in your microphone, increase the echo. Okay, now we can start with the question by our colleague. And I have the first question for you. What is the role of the fascial manipulation in combination with the exercise to restore the fascial situation inside of the pelvis in these patients? Now you. Okay, perfect.
Okay, yeah. Yeah, good question. I use it to support the changes that I make in the connective tissue. I don't count on exercise to make the change. I think you could maybe exercise a fascial densification away if it's not too established and if they're not too widespread for people, but otherwise I think the manual component is important. At the same time, if I do really good work with somebody in a visit in the clinic, let's say I work on anti-pelvic or some other point, and then they go out and they're sitting for hours on end and they're shortening that tissue. You know, immobilization is one of the keys for overloading tissue, and so they might undo the good work that we did with our fascial manipulation. So I teach people, well, you're going to need to get up, intermittently and stretch the front of the hip. I use a lunge a lot with people because we all tend to sit a lot, like we probably have been doing throughout this webinar. So I use it to support the changes and then also help undo the negative overload that people may be putting on their body. But I feel like if we put that first, as I was saying about the muscle spindle and the Golgi organ, I don't think we can stretch or strengthen and expect a change in somebody if the nervous system element is embedded in a non-elastic matrix. I think we're wasting our time. And I think that's where a lot of our exercises for classic physical therapy might fall short, because we're not looking at the physiology and doing things in a good order. So I don't count on it to make the change, but I like for it to support it.
Great. We have the question by our colleague, by Van Reichendam. What can improve with women who have diastasis and prolapses after FMIT? Is it possible they disappear?
Yes. Now, I don't know what it means after FMID, but I don't think it's from the fascial manipulation. But a diastasis, in a nutshell, I usually find that there's a densification in medial lumbi at the most superior aspect of the split. So I'm palpating medial lumbi ante, and there's usually a densification at the top of it, wherever the split begins. But there's also densification somewhere else in lumbi or pelvi that's putting stress on the tissue. And then when there's expansion in the volume of the abdomen, whether it's from pregnancy, but it doesn't even have to be. It can be from a weight gain, or it can just be from our internal organs fluctuating in volume. And if the trunk is non-elastic and it can't accommodate that expansion, then it's going to split. So you have to address all aspects of the trunk as well as the lower limb. And I have seen them heal up nicely. The diastasis, prolapse, it's the same construct. I see it, it's almost like a hernia. Internal organs don't like it if their house is not elastic and flexible. And so if the trunk becomes inelastic, then the organs are going to take the path of least resistance to try to create the vital space that they need. And they may herniate, with an inguinal hernia, umbilical, hiatal, or prolapse. Prolapse is very similar in that it's just about a loss of space and a loss of slide. But especially in prolapse, I believe a lot of it comes from the lower limb and that tension pulling down on organs that are already struggling in the environment of the trunk. And so the prolapse happens then. Resolve that, and a lot of this can be restored to where it was. I think it's why the surgeries fail so much, especially for prolapses, because nobody's looking at the lower limb and the elasticity of the whole system.
Great. And we have any idea about
Yeah, well, good question. I see mostly adults. When I see children, I'm often seeing them with a lot of constipation issues, which I think it's great to address it in children, because I think when we leave it go in the children, it becomes a problem of a different sort in an adult. So, but the incontinence in a child can be stemming from an unresolved constipation problem. So that's the first thing I think of. I mean, some of it can be from, stress or, a tough home environment or emotional stuff going on. All of that needs to be addressed with the kids. And I don't think there's any one good, quick answer with it. But I think it's like anybody else. We have to look at all the possible components of the problem. But I do think it's unfair, especially for a child, to put it on an emotional component when just because nobody's known how to look at the fascial component. But even if it is constipation in the child, it still can respond very nicely to fascial manipulation. So I find it takes me to the same place anyway. Sometimes too, I think the emotional stuff that the children have is because they're having so many internal organ problems, and maybe the emotional aspect is really the effect of these internal organ problems and not necessarily the cause of it. As far as a percentage, I don't really have a comment on that. 100% of the patients I see with urinary incontinence have fascial dysfunction. So I would say 100%. So there.
Okay, we have the last question. Do you create some extra special trainings or only consistency as we have the problem?
I'm not really sure what the CCs and the CFs that we were taught for the pelvic floor are. So I don't know if we're talking about specifically on the pelvic floor, but I will say I keep an open mind. Initially, I would go at a patient with the idea that urinary incontinence is going to be, I should expect to find the antemedial diagonal and the retromedial diagonal probably being the likely culprits. And I've really had to back myself away from that expectation, because sometimes, as I mentioned earlier, constipation is what's driving the bladder issues. And so that would take me to a different tissue line of maybe a retrolateral and antilateral, but the horizontal plane can be hugely influential too. But I think you have to be open-minded to any of these fascial points causing problems, and that you need to check them all out. I look at all the CCs and all the CFs in the segment that are related to the problem, and then down in the lower limb when I'm talking about pelvic problems. I'm not really sure, like I say, about specific what someone was taught specific for the pelvic floor. I find that the medial aspect of the lower limb may be related to Carlos Decco's research about the continuity of the external oblique crossing over at the pubic symphysis and then going down into the contralateral lower limb, and especially the relationship with the adductor fascia into there. That is involved a lot. So I just make sure I check them all, though. I try not to have a bias or an expectation of what I'm going to find.
Okay. Could you decrease or turn off the volume when I talk, because there is echo? Okay, great. Okay. There is another question by Lemina Ido, and this is the last question. I have a patient who is an above knee amputee since a year ago and woke up following the surgery with complete incontinence as well as a lot of trauma to the other limb. Suggestion: she has improved with formal bladder training.
Well, if that's working for her, then I would say there must be something good going on with it, and continue it. But maybe with fascial manipulation and addressing fascial densifications, that might be interfering with the integrity of pelvic floor, or putting abnormal tension and stress coming from, even though the lower limbs are less of a factor, but there's probably still, I don't know if it's above knee. Yeah, you have above knee. There still may be some fascial densification occurring into what's left of the limb. I would still look at that. I've never dealt with that. It's a pretty complicated case. But I would say couple it with whatever's already working, like the formal bladder training. If that's giving the person some help, then that's noteworthy. But I would just superimpose fascial manipulation and see if you can get an even better result.
Okay. Okay, Colleen, we finished. Thank you for your presentation, for your speech, and I think that we will meet again for another your webinar, another speech for our Wednesday webinars. So thank you so much for your speech and your presence at the webinars organized by Fascial Manipulation Institute by Stecco. So I want to remember to our colleague that the next event it will be on Wednesday, March 8th. with the title Animal Fascial Manipulation and Treatment Tool. The speaker will be Tulia Luomala. So thank you so much for your attention, and see you for the next appointment. Bye bye.